Hi everyone and welcome back to Placement Series. This is episode 3 and in this episode we're continuing to look more in detail at respiratory placements. So without further ado, let's roll that video. So, hi everybody and welcome back to the Placement Series, bringing you clinicians and educators from the real workplace to give you advice on placement. And today we are joined by Ema Swingwood, who is going to give us a load of information and advice on respiratory physiotherapy. So Ema is currently an NIHR Clinical Doctoral Research Fellow and Chair of the ACPRC, which is the Association of Chartered Physiotherapists in Respiratory Care. So welcome to the channel and welcome to the series, Ema.
Hello, are you all right?
Good, thank you. How are you?
Fine, thank you.
Excellent. So this is obviously, as I've said before, respiratory physio is probably arguably one of the most nerve-wracking and daunting placements that students often have. And I don't necessarily think that's founded in what they actually experience, but it's just something we all think about, isn't it? So what we thought we'd do today is just give a bit of overview of what your role is currently now in terms of your having students and in the NHS.
So as a physio, we have students throughout the whole academic year, which is really nice. And as an educator, in a way, I feel that obviously we're there to teach you stuff, but very much there to just encourage and nurture and enable you to kind of grow those physio wings, and then you can just fly by yourself and be fully independent. In the role that I'm in at the minute, as a researcher, I don't have to have students per se, but we're actually going to try it. It's good to try different placement models, but clinically, the role is to have the student with us on the wards, experiencing exactly what we experience from 8:30 through to 4:30 or whatever working pattern we're doing. Weekends also, I think, is really important to experience, to do the whole shebang working pattern. And just see where we get to from start to finish, really. For an educator, it's a really satisfying process to go through, I personally think.
That's great, yeah. And I think it's exactly the type of educators we want, people like that in terms of finding it something that they really enjoy. So let's kickstart this with the first bit that I often get messages about, and that's how to prepare for a respiratory placement. What are your tips and tricks on and advice for students preparing for their respiratory placement?
Don't panic. And I think for me, I really like it if a student has made contact first. And partly because I want to know that they are also planning on arriving, and that they haven't forgotten they've got a placement. That's always quite handy. But it's much for them to get information from us, because having, the title you get as a student is, I'm going on a respiratory placement. Well, actually, that can mean so many different things. And even just saying, oh, it's an ITU placement or it's a medicine placement. Well, still, what does that mean? Is it just general medicine, or is it that actually they've got CF there? Or is it a specialist centre that has CF as a placement in its entirety? So find out exactly what area of respiratory you're going to, because that will really help you plan and prepare. Because otherwise you could be wasting your time reading about stuff that you actually are not going to come across at all.
Of course. Yeah.
So make contact with them. But also, for me, the educator on the other end of the phone, it's really nice to just have a quick chat with the student as well. I want to know what their name is properly. Don't always get it in full on a piece of paper, so that's really nice. In a way, it's if there is the opportunity to have a proper conversation, they're just getting a brief overview of how they learn, and then I would plan a timetable accordingly. And just little things like that makes it easier for us as well. And then we meet on day one and off we go. Yes, doing some prep beforehand it is super important. You can't arrive on placement being an expert. That's not the point. And you can't arrive on placement being the same level as the band 5. That's not the point either. The point is to get loads of patient exposure, practice getting all your aprons and your pinnies on, practice writing notes, just practice being in that environment, learning how the MDT works, so on and so forth. It's just exposure to everything.
Yeah.
But if you can just plan and just, have an idea of what you're coming into, that makes a massive difference. I guess prep wise, you can always know a basic respiratory assessment. That's the easiest thing to learn and regurgitate off, from the top of your head. That's fine. Yes, a bonus if you know your blood gases, but to be honest, I wouldn't waste my brain cells. I'd have them written on the back of my badge, so you've always got them there at all times, But then what you can do is, if you've got that nailed, rather than having to learn it whilst you're on placement, you can then be almost applying it more, and then you're learning about the application as well. So it's nice to then be that slight step ahead, and then we can then build on that. But if it's not something you've managed to get to, it's fine. We'll teach you at your on placement.
So you then goes into your learning objectives.
Absolutely. And to some extent, if you arrive on placement not really of preparing anything, you need to still, there has to be meet somebody somewhere halfway, I think, if I'm honest. But I think basic prep, don't spend hours, have an idea of what you're going into. If it's surgery, what kind of surgery, just so you can have a think about your incisions, for example. If it's an ITU, what kind of ITU? Is it a general ITU, a cardiac ITU? And so you can then have your basic assessment and then think about those slight tweaks that you might need to make for that specific speciality.
Okay. Yeah, definitely. And what about your overall pathologies and things like that? So if you're going into respiratory placement, so it's the first things that come to mind. You mentioned CF, COPD, things like that. How much should a student be really aware of those pathologies and those conditions?
So, I mean, yes, it definitely will help. If you were coming, so at the minute I'm based, this week's been in acute medicine. So if you were coming to a placement, we'd really be like, can you please look at COPD, bronchiectasis and pneumonia? Because that's going to be the most common caseload that they come across on these specific wards. And really just a basic understanding of what that is going to be really helpful, because then we can start discussing that and then linking it to how they're presenting, and almost what their problem lists are going to be, and then what goals we're going to generate, so on and so forth. And it will just really help them from a clinical reasoning perspective, because none of these patients are, well, no patient really is a protocol. There's no flow charts of how to treat a patient. Everybody is so different. So unless you know some of those basics, you're never going to be able to clinically reason and kind of come into the right treatments and stuff and select the appropriate techniques.
Gotcha. So really coming round about there, it's getting in contact with the placement, with your educator, and getting some detail as to where you're going to end up and what sort of things you might be dealing with, and then you can then make a focus plan on what you're going to prepare, rather than just doing a blanket, I'm going to prepare for a respiratory placement, because that's that's the university degree, isn't it, really?
Well, I mean, I've been qualified for too long, and I don't know everything. So how are you going to prepare for respiratory as a whole in a few weeks before a placement, when you've got so many other things going on as well? There's always concurrent modules, and they deserve equal attention. So don't put yourselves under pressure. And I would expect the educator to be able to guide you of what to prepare. If somebody asked me that question, I would be like, basic respiratory assessment, COPD, bronchiectasis, pneumonia, done. See you Monday. And that honestly would be sufficient. We'll build on the rest whilst somebody's with us.
Perfect. That's great. I mean, that's a really, really focused preparation, because I've seen, see it, and I've been there where we've tried and do so much preparatory work to try and be the best we can be, and we want to arrive almost sort of showing off, oh, I've done all this work, I know this, that and the other. But I also know that I've done that before, and then I've arrived on placement and I've suddenly go, oh, that's what I'm doing. And half the stuff I prepared not actually, not useful. So that's really good and really focused. Okay, so we arrive on placement day one. What sort of things might a student who's going on a respiratory placement expect? Now, I know what we've just said there, that respiratory is really broad. So can we pick it apart a bit and sort of think about what we might what students might be expected or expect to see and expected to do on a respiratory placement?
So I think by the end of a placement, no matter what year you're in, because obviously you can have placements across the whole of your degree, you would be able to manage an appropriate sized caseload by the end of your placement. And when I say appropriately sized caseload, if you were a year 3 student on, say, a medical ward, we would expect you to be able to run that ward pretty much by the time you leave. And that is totally doable.
Yeah.
But obviously in comparison to a first or second year, that's a little bit unfair. But then we would almost just box down your caseload, and then that would be more appropriate. So to manage a caseload, to increase understanding of how to assess appropriately this, the relevant patient group. So that's obviously your basic respiratory assessment with any relevant tweaks for each, for each speciality. And then to be able to generate problem lists, goal set, and then obviously treat patients. And so it's not all about, I know this about pneumonia, that about pneumonia, and a bit more about pneumonia. It's actually, I've really learned some really valuable communication skills. Yeah. I've learned, and I now understand the role of the occupational therapist, the speech and language therapist, the dietitian, and how we all work as an interdisciplinary team with the nurses, with the medics. So I think it is, patient exposure is invaluable, don't get me wrong, but it's everything else as well that then all comes together. So I think, it's, for me, it's getting as much out of the placement as possible. But those things for me, so obviously the clinical skills in assessing problem lists, treatment plans, and then, putting those into action for sure, managing a caseload, communication, and just gaining knowledge about how things run in all of these different settings, because everywhere's so different.
Yeah, definitely. So what sort of kind of treatments might a physio student be doing on placement? Because I think that's one of the other things, because respiratory tends to come with the word suction. I think we kind of put that out there because it's something that a lot of students go, oh gosh, will I be doing that? And I, as a new band 5, still, it's one of those areas which I think for some reason or another really does scare us a little bit. So what sort of treatments might we be doing on placement?
Getting people up and mobilising them. So simplest way to make somebody take a deep breath. So everybody can do that. Things like active cycle of breathing, breathing control, manual techniques, so vibs, shakes, percussion, however you've learnt them. And then obviously you've got your devices, and I think this is where people get a bit, I can't, don't worry about learning devices before you come. The easiest way to learn about a device is to practice with it with a patient, without a shadow of a doubt. So, and you can't, I remember as a student writing an essay on non-invasive ventilation. I'd never seen an event ever in my life. I didn't think what I wrote in that essay. It would have been pure gibberish. It would be horrific. But now as soon as you see it, you're like, I get it. And then it just makes it so much easier. So device-wise, obviously you've got oscillating PEP devices, of which could be an aerobica, an a cappella. You've got obviously the bird, the cough assist, or manual insufflation, exflation. Then you've got ventilators, so on and so forth. But again, keep it simple. You don't need to treat everybody with a device that needs a plug. Quite often your hands are the simplest things to do. And then, communication is one of the best things because of education. You need to educate these patients. Right. So, if it's a long-term condition, have we educated them and given them the skills and the knowledge ourselves to be able to manage their long-term condition themselves? Right. Or if it's an acute patient, say post-op, have we given them all of their post-operative advice that they need to then keep them progressing and getting better once they're back in the community? So it doesn't need to be complicated. No. So the simple things, and I think, am I right in saying that sometimes the simple things are the most effective treatments anyway? Absolutely. So that's important. Okay, that's great. So we're on placement. We've kind of got a bit more of an idea of what we might expect to be doing on a respiratory placement. I think we've already hopefully
alleviated some nerves, and trying to keep things simple, and expectations actually aren't that you're going to know everything and every device and how to do all the treatments. So that's great. How can a student get the most out of a placement? What are your kind of best bits of advice for students, and from your experience of having students in them, getting the most out of placement?
Ask questions.
Yeah.
And if you've asked a question and you still don't get it, just ask the same question again. Don't be afraid of asking questions. Nobody knows everything. I might not even always know the answer, but then we'd find somebody who does know the answer. So just almost bleed us dry of information. We should be exhausted by the end of the placement just as much as a student is, and that's really important. So ask questions. And actually, an educator does learn just as much having students, because we're challenged in the way that we explain things, because my first way might not work, so I need to have a second and a third way, and that's important for us as well. So ask questions, and just take time. Don't expect to be an expert straight away, and just make the most of the experiences available. So if you're on a surgical placement, if there is the opportunity to go to theatre to actually watch the operation that you're then treating, I think that's a really cool experience. Just because you can picture then what's actually happened, and take the opportunity to spend time with different members of the multidisciplinary team. So yes, it won't necessarily contribute to your mark per se, but actually you'll be a better physio for having that understanding. And just try and enjoy it. And if you're not enjoying it, or if you're struggling, or if you need information given to you in a different manner, or if you're just really unhappy, you need to say something. That's really, I do remember a student quite a few years ago now, not in the trust that I'm in, who at the end of placement kind of opened up and said that there was such a lot going on at home, and I was just gutted, because it just meant that I knew that they'd struggled through so much, and they'd done amazing on placement, but I knew that there was more in them. And so I was like, well, why aren't they engaging with me? I just don't get it. This is really frustrating. And actually it was just because they had so much going on, and I just wish they'd have said and felt comfortable saying. But I think, well, I know now that they were really worried it would be held against them, and that that would never be on. So just be really honest. If things aren't going to work, you just need to say. So obviously at the start I said about working weekends. I do feel quite strongly that if you're on a placement, it's really helpful for you to mirror your educator's working pattern. So then you're spending as much time with them as possible. But if actually weekends really don't work, or a late shift, or whatever it is, you just need to say, and then we'll kind of muddle through and juggle things around, and that's fine. I just people, I want people to, not everybody's going to like respiratory. I've come to terms with that now. I love a bit of phlegm, but I know that not everybody does. But even if you hate respiratory and you know that you want to do neuro or musculoskeletal, we can still make it a positive learning experience for you. So almost being open and finding, which bits you do enjoy, then we can try and manipulate a caseload accordingly and appropriately, because obviously you need to pass. But there's ways around things to make it more enjoyable, I'd hope.
I suppose that's quite an important point you touched on there, is that sometimes, I certainly wasn't like this at all, because I had no idea, and I still don't really know which way my physio career is going to go. But some people do, and well, maybe. But some students will go on to placement, and they will be, I am going to do this. I am going to be a sports physiotherapist, or I want neuro.
Yeah.
And I think especially if you want to do neuro, or you want to work with older people, etc., you're going to need to have a really good grasp of respiratory care. So I think putting placements in pockets sometimes can be a little dangerous, actually, because
definitely
having a really broad knowledge is really key. Would you agree with that? Is that something?
Totally agree. And I think it's totally vice versa as well. So on respiratory, there is so much rehab, especially on the kind of intensive care areas, much complex rehab. Patients who are tubed can still have strokes. This happens such a lot. So you do need amazing handling skills, which you won't necessarily get from a medicine replacement, you know. So just as many skills if you've got, because you're never only going to treat the COPD, you're always going to be looking at everything else as well.
Yeah.
And how many patients have one problem? Like, that just doesn't happen nowadays. So no, you're totally right. And actually you find that when you have clinicians and students who come into the team, though, especially I notice it very much so with those the band 6 group who have been band 6 rotational therapists for, you know, a good few years, and they're very happy at being band 6 rotation, but actually the skills that they bring into a team are unbelievable because they've had so many amazing rotations.
Yeah.
So it's invaluable.
Yeah, and that comes back to that we're treating a person, not a respiratory patient or a patient with COPD. They are a patient who has come to us as a person, and as you say, invariably they have plenty of comorbidities. I'm currently working on older adults ward at the moment, and you know the diagnosis or comorbidities is a A4 page long, and I'm picking all of that is really important. So when you go to your next placement, having these really good respiratory skills is going to go forward as well. So
I'd hope so. And I think with the older persons, I mean, you could approach, I know we're talking about respiratory, but you could approach older persons, and we do hear it even from qualified clinicians that, oh, I don't want to just be walking old people. But actually you'll get out of a placement, rotation, whatever, what you put in. But also, like in older persons, you've got all this silver trauma, the low velocity fallers who then come in with multiple rib fractures. Well, in essence, you've there got a blunt chest wall trauma. And actually they need respiratory monitoring and intervention because at day 3, that's when their chest is going to go off. And it's things like that actually, if you try and consider your other placements and think, okay, actually don't, like you say, don't park it because you've done neuro, tick that box, and I've done, you know, respiratory, tick that box. Try and bring as many skills from each of your placements into the next one. And then you're gradually, you know, you're growing and growing then. That's really important.
Yeah, no, that's great. Okay, brilliant. So Emma, just any other particular bits of advice you've got for students? Any more nuggets that we can share?
So the only other couple of things that I've written down are, first of all, about the use of peer review and peer support. So it probably links quite nicely to multiple students to one educator. It's a similar thing. So where I work currently, we've over the last few years almost tweaked how we offer our student placements, in that we've tried now to offer all of the respiratory placements in one batch, if you like, and then the next lot of students would all be rehab. And the reason for that being that induction teaching can obviously be across, it's less intensive, labor intensive for us, but also so then the students get used to working with other students as well. So we would, or how I've done it before, is that then week 1 they'd actually have almost half a day of non-clinical, but all of the students would come together. And say, for example, week 1 would be, you know, really nail your respiratory assessment like we talked about, but actually you're all coming now from different respiratory specialties. So nail your respiratory assessment together, but then share your experiences of how and what's been tweaked because of your patient client group that you're working with currently. Because that way, me being on an intensive care placement, I'm going to nail that, but then I'm also going to start getting an understanding of how I use my bog standard respiratory assessment in CF, in home NIV, in surgery, in cardiac. So I wouldn't expect then you to know it all, but it just gives you an inkling of which bits you might be tweaking, and then you can build it up over the week. So the next week might be share some problem lists that you've been generating, and you start to build pictures then of the different patients across the patient group, so on and so forth. But also, you know, some students don't like asking questions. I know that, but I mean, it's really important. But sometimes use your peers to do that, and if there's problems, work it through together. You know, shared reading, finding journal, you know, all of that stuff is really invaluable. I've just had some really positive results from doing that.
I think that's really, there's a couple of things there. Obviously, the sharing as students, I don't think I see it enough where students share with each other, journals and things that they've learnt. I think it's great to see that sort of stuff. Now, if you've got a placement where you don't have someone else or educators that are kind of facilitating peer ed, we could still do that, couldn't we? You know, if you
Absolutely.
university and you know you're going off on a respiratory placement, you could potentially find out who else is going on a respiratory placement and set up a little
Definitely
group.
Nothing like a WhatsApp group.
Yeah.
But also Twitter, like social media, the amount of kind of networking you can do on there. So if there is something like, oh, actually, I'm really looking for an article about this, the likelihood is that a qualified clinician who specialises in that area is going to have it totally to hand. So it's no extra work for them just to ping you a link. So don't be afraid. Don't think, oh, but I'm a student. Can I approach them? Yeah, of course you can. Why not? There's no hierarchy here.
No.
So yeah, just ask. Like I say, ask questions.
Yeah, I think it's brilliant you mentioned that, because I have found Twitter particularly, because I've used Twitter solely as a professional platform, but there's stuff that you can just ask a question and the people who will respond are people that you'd never think in a million years would, you know, you'd be.
It's amazing.
But Twitter just levels everyone.
Yeah, absolutely. I get proper fangirl moments. I get really excited. I'm like, oh my God, you just replied to my tweet. Oh. Yeah.
It's great. I think it's, you know, in my second year, I realized that. And I get now, it's brilliant. I see first years put up, I'm about to start placement here, any tips and advice, and I'll retweet it. And the amount of stuff they get from really eminent physios out there, really experienced physios, and new other students as well. So yeah, big tip, use social media for the good.
Yeah, do. And did you say that you'd had queries about almost multiple students to one educator?
Yeah, definitely. I think that sometimes there's a bit of apprehension on sharing an educator. If you've got two students with one educator, will both those students get as much as they would do if they were just one?
I mean, I don't see why not. I've never had a problem with doing multiple students. Well, I hope not anyway. Not that anybody's told me, but that could be a bit awkward, isn't it? I could get some messages after this. But I've never had a problem. And actually, in a way, it's nice because initially we probably all start off being together. But then actually, rather than doing things with the educator and then doing something with like by yourself, you've almost got a step in the middle, because you can go off and do what would be a single patient, if you like, but you can go and do it together. And then you can give each other feedback, like, oh, you actually forgot to ask this, maybe make that a priority for your next one. And hopefully that's less daunting actually than us standing there watching. And I'd hope that we wouldn't just stand there arms folded watching with a clipboard. That's not a nourishing environment at all. But I think it's just quite a nice interaction. You can support each other through it, and then kind of once people have built up a little bit of confidence, then you can start working by yourselves. And actually how we've done it before is, yes, we're on a ward, we might split the ward. So it's just making those roles and responsibilities really clear. So at board round, you've got beds 1 to 10 are yours to discuss, 11 to 20 are yours for example. So that's important, but that would be my role to make that clear. Not, they don't need to worry about that. And then we go for it. There shouldn't be a conflict of time at all. I mean, I guess the caveat to that would be if you've got a student who's really struggling and then a student who's really excelling, because you need to spend time with the student who's struggling to make sure that we're approaching the placement in the right way for them, and that we don't need to tweak things. But at the same time, just because somebody's doing well, we can't just leave them to it. We need to be challenging them to make sure they get as much out of it as possible. So that can be hard. But if that's, if you've got two polar opposite students, I, to be honest, would expect an educator to flag that and then put appropriate measures in place. So it might be actually you start as a 2-for-1 model, but actually by the end, because to prevent anybody failing, you never want that, you might actually split and get another educator on board as well. And I think people understand those situations.
Definitely. I think that comes back to what you talked about earlier about the students taking a little bit of ownership and being honest and saying, I'm actually really struggling, or I feel like I need this, etc., etc. Being open and honest is vital on placement, isn't it? To get the most out of it.
It is.
Yeah, to
It
be
is,
selfish.
and not everybody learns in the same way. And I think initially when we went to our educators course and we're told, make sure you ask what their learning style is, I was like, oh, this is really wishy-washy. Oh, I hate this kind of stuff. But actually, the more students you have, people do learn so differently. Some people like that PowerPoint. Some people are just very hands-on. Some people need to listen and make notes. Some people just have this amazing memory. And I'm like, how have you remembered that? Like, I don't even remember that conversation from yesterday. But it is important because the placement will then look different.
Yes.
And if we're asking you to do a little bit of work at night, which you should expect, I would then be saying, actually, could you do this, this, and this? But each person would be different, and I think that's important too.
No, that's great. Okay, brilliant, fantastic. Anything else on that wonderful bit of paper of yours?
You're not supposed to say I've got a piece of paper.
I'll cut that out.
No, it's okay, don't worry. The only other thing I find that we end up talking about a lot on placements is the generation of a problem list, because it's always labelled in their marking scheme, and so people want to do it well. So what we tend to get initially is like an amazing problem list, but it's like so detailed that actually the key points are then lost.
Right.
So how we tend to just, my brain is super simple. So for me, there's only 3 respiratory problems ever. I'm going to read them now. How bad is that? But no, not really. So reduce lung volumes, increase work of breathing, or retain secretions. That is literally it. So people then go, no, there's way more than that. What if their cough's really bad because they've got loads of pain? Well, I'm like, well, they've got retained secretions, which is their problem, because of post-op pain. So they don't want to take a deep breath and they don't want to cough. And in a way, it just makes it a little bit simpler for people. So you can choose one of your 3 things, or 3 of your 3 things, whatever, and then do the because of, and then start chatting about that. And I think by doing it like that and breaking it down, you then start to see the clinical reasoning links. And that's when you can then start bringing in, a student will get so far with that sentence, and then it's for us to then build upon it. So it might be that they've got that because of pain. Well, okay, well, what's the next because? And that's when you can then bring in your pathophysiology, so on and so forth. So it makes it easier for us to start explaining and stretching them and pushing them to learn more. But then it's not too intimidating, because you can, see it as a tick box. Tick 1 of 3 boxes, tick 2 of 3 boxes, tick 3 of 3 boxes. It's fine. But then we can build on that. So keep things simple.
Yeah. So can you tell us, what are those 3 things again?
They are reduce lung volumes, retain secretions, and increase work of breathing.
Fantastic.
Full stop.
Full stop. So those are your 3 things to identify where is that patient going, and that comes from a good assessment.
Yes.
And then from that, you can then come to those problems. What's causing those problems? Is that right? So
yeah, absolutely.
Lead that conversation on, and that's a good thing to have with the good clinical conversation to have with your educator, to show your understanding and assessment skills. Yeah,
absolutely.
Yeah, that's brilliant. Question then, so why did you choose respiratory physiotherapy on the spot?
Because I say I prefer acute, but I also really love long-term vent and stuff. But I like the fact that you can do an intervention and you can see an absolute immediate response. So I personally really like the pressure that you actually need to make a clinical decision about 30 seconds ago. I quite like that pressure. I know it's not for everybody, but I quite like it, and that's the only way my brain really functions. If I've got time to make a decision, I'll use all of that time, so that's not very time efficient. I love phlegm, and I like the fact that with respiratory, you really do get to know your patient. So even if it's an ITU patient, you still get to learn a lot about them, and so you really get to build a relationship with them, all the way through to your long-term ventilation patients, your neuromuscular conditions. You get to know those patients for years, and which is so sad. It's so lovely. So sad, obviously, when then they kind of RIP, go to Rose Cottage, but it's still amazing. So I like the pressure, and I like the variability. There's absolutely not one day that it's the same. Absolutely never one day. So that's really nice. Really nice.
Exciting, isn't it?
Yeah, exactly. Keeps it varied. It's good.
Varied is good. Yeah, as a student, not sometimes I think as students we kind of like things to be do, but that's just not the way it goes.
No, it's not. But if if too many things is a bit too much, then we just limit the caseload to, let's start with some bronchiectatics, let's start with COPDs and build it up. So it's doable.
It's doable as long as you talk to your educator. So I think
Yes.
that's a big one that's come out of this is again keeping it simple, which I think is probably the
Cool.
same in every area of physiotherapy. That's no
Yeah.
different. And talking to your educator, so they're really aware of how you're doing, so they can then make modifications and change things for you. So respiratory is great, not scary.
No, it's not scary, honestly. I mean, it can be a bit tense sometimes if someone's plugging off and you're like, oh, they're definitely not breathing, but it's okay.
Yeah.
And the nice thing is that obviously when the alarms go off because something like the sats have dropped or tidal volumes have dropped, for example, when vice versa, when they're also good and you do something to make somebody take a really big breath, a ventilator will go beep, beep, as if to say, well done, that was amazing. And you're like, oh, yes, thanks. So just take it. There's pros and cons to everything. It's fine.
But in those situations, you're around lots of other people as well, aren't you? You're not on your own.
Absolutely. No, you're really
as a
not.
student,
So
you really.
yeah, oh, totally. No. There's always somebody around.
Yeah. So it's to take that reassurance as well. Well, Emma, I shall let you get on with your evening. Thank you so much for your time this evening and going.
No worries, Angie.
Respiratory care. I think we definitely alleviated some nerves for sure.
I hope so.
That's what it's all about. And I think maybe I think definitely get you on for a couple of other things we've talked about outside of the interview. I think we're going to get you back on at some point if you're okay, just to go into more detail.
Yeah, let's do it.
It'd be really good. So thank you very much. And
no, you're welcome.
We'll hopefully speak to you again soon.
Yeah, perfect.
Thanks, Emma.
Right. Take care. See you later.